Well, thank you everyone for attending this live webinar today with Professor Patrick Kwan. Today is our third workshop for our AI in Healthcare series workshops, which is supported by the Medical Research Future Fund and is really intended to bridge the gap between medical researchers, clinicians, and technologists in understanding and developing a sense of the potential for machine learning and artificial intelligence in healthcare, and some tremendous progress and research which is already happening in our backyard in Australia. My name is Zachary Tan. I'm one of the research fellows at the University of Melbourne Centre for Eye Research Australia. And today I'm very much delighted to welcome Professor Patrick Kwan to speak to us about his research. Professor Kwan is a medical specialist in neurology and is international authority in the subject of epilepsy. Professor Kwan's research portfolio encompasses both applied basic science and clinical aspects to improve treatment outcomes, including translating research findings into the practice of personalised medicine for epilepsy. Now, it's a real privilege today to hear from Professor Kwan about his research and his collaborations with medical AI scientists, including the development and a validation of a world-first machine learning model to improve an individual's response in the treatment of epilepsy. And I'll hand over to Professor Kwan very shortly to share his presentation. I would encourage everyone as well to please share questions as our webinar proceeds. So you are very welcome to include, to provide us with questions in the Q&A box within a Zoom chat. Today's webinar is also recorded as well. So for those who are unable to make this session live today, we will be uploading this to YouTube later on in the week for others to refer to and to review at a later point. But without further ado, I'll hand over to Professor Kwan to speak to his fascinating research, his truly innovative research, and excited to learn more.
Okay, shall I make a start? Zachary, yes. Can you all hear me? Great. I just share screen. So first of all, I'd like to thank the organizer for the invitation. Can you see the slide? My first slide. So thank you very much for the invitation, first of all, and in particular, I want to thank Dr. Zhongyuan Ge, who I think is one of the panelists, and this is very much related to some of the work we've been working with Zhongyuan, and one of the very important medical AI project that my group has the opportunity to collaborate with Zhongyuan. So as you see, the title is around using machine learning for personalized epilepsy management, in particular how we can use drugs better for individual patients. And you might have come across quite a lot of work in using AI machine learning for other aspects of epilepsy care, in particular EEG analysis. There's a lot of work going into developing algorithms for automated EEG analysis or wearable devices for seizure detection or prediction or image analysis. However, there's much less in exploring the use of medical AI or machine learning approaches to drill down to decision making as in a clinical level. And the reason we are interested in this is very much based on my background as a practicing clinician. And so that's my first disclaimer, is that I'm not an AI scientist at all. I have no background in, I don't know how to code. I'm learning all the language of machine learning through working with people like Zhongyuan. But I've really enjoyed the collaboration and have had my eyes opened up to see what the opportunities there are. So just a bit of background, and I'm assuming most people on the call are not clinicians, and are not even your clinicians. You're not familiar with epilepsy as a condition. Epilepsy is one of these conditions often considered as hidden because patients have episodic manifestation is very invisible. There's no visible disability per se, because the people with epilepsy, their seizures can happen very infrequently. So in between the seizures, they may act and behave and complete as a normal person sitting next to you. But in fact, it's a very common condition, and there's many epidemiology studies done in the last several decades have shown that nearly 1% of the population will have epilepsy at some point during our lifetime. And it affects all ages, although there is a bimodal age distribution in the sense that it's more common in the young children, in pediatric population, and then the prevalence decreases as you get older, but it rises up again. So in fact, the highest age group now being affected with new onset epilepsy is in the older population, over 65 years old. Epilepsy is also not a single condition. It's in fact a very heterogeneous condition with multiple different causes, which can be genetics, could be metabolic, or a structural lesion in the brain, for example, a severe brain injury, or after a stroke, a brain tumor. These can all cause epilepsy, manifest epilepsy, because the underlying characteristics of epilepsy is that patients have recurrent seizures, which are unprovoked, which means that the seizures can happen apparently out of the blue without an external immediate cause. And this is because these causes I've explained have led to an intrinsic abnormality in the neuronal network. And a seizure happens when there are abnormal neuronal discharges in these brain cells, essentially, and that manifest as different forms of seizures, which I'll show you some example a bit later on. And because it's so prevalent, you may or may not actually know someone who actually has epilepsy. And I wouldn't be surprised if you've seen one as a seizure before. And because of their unpredictable nature and the loss of control by the person during a seizure, you can imagine people with epilepsy can suffer from a whole range of complications from the seizures, so directly from injuries, etc. But the impact is really beyond just seizures. And that's because, again, because of the nature of the condition, there's a lot of misunderstanding, even stigma in many parts of the world. There is tremendous psychosocial impact, and the impact is not in the most obvious would be patients will not be able to drive if they still have seizures. There are clear guidelines from big roads that you need to be seizure-free for at least 12 months before you can drive. So they lose their license, and it can impact obviously on their employment and their other social aspects. But there's also increasing realization that there is a bidirectional relationship between epilepsy and many main brain conditions, such as mental health problems. They're not just a reaction or psychological reaction to the diagnosis of epilepsy per se, but in fact, it's because of other neuronal consequences from the abnormalities in the neurobiology level. And patients also have higher mortality as well. So usually the most studies have shown that patients with epilepsy are up to 4 or 5 times more likely to die than someone in the same age group and the same sex. And that may be because of many reasons. So because of all these reasons, then you need to, there's a great need to control the epilepsy. And the way it's controlled at the moment has been with medications. And these medications have been developed for many years, and their function is to suppress the seizure occurrence. And this is an important concept. So the drugs that we have currently available are not curative. They don't cure the disease. They control and reduce the chance of the patient having the seizures. So in that way, they're a bit like someone with high blood pressure, hypertension. They take antihypertensive medications. If they stop the medication, then they will start having seizures again. The drugs have been very useful for many patients. So I said I'll show you some seizures, and these are just a random collection of different types of seizures. And you can see these are all seizures, but they can look very different. The patient on the left-hand side here is having a seizure with, these are involuntary movements, but he appears to be awake, and after seizure, wide awake, he could call the nurse. And this sort of seizures, whereas the one in the middle here, the patient here, he looks very blank. If someone was to interact with him, he would be unresponsive, and his behavior is much more subtle. Whereas the one on the right-hand side you just saw started with a few body twitches, and then now progressing to a much more severe seizure, where she's clearly what we call convulsing, with twitching her arms and legs, and she might, in these sort of seizures, the patient may bite their tongue, lose control of their bladder, become incontinent. And you can just imagine, these are patients we bring into the hospital to monitor the seizures, and they're sitting in bed or in a chair in a safe environment. If they were at home in the community, you can imagine having a seizure like this. They fall over, they can get very serious injuries. But the point of showing you this is to show that the seizures can be different, and we give them different names based on whether the patient's aware, whether there is a focal onset of the seizure that starts in one part of the brain or spreads to both parts of the brain when it becomes what we call a generalized seizure. So currently, the way we classify seizures into 3 different groups based on these manifestations, the behavior side, but also the EEG changes. And I'm not going to show you a lot of EEG, but the point is the EEG is there to help us to characterize the seizures, to decide into these 3 broad groups. And essentially, you can say actually there are only 2 broad groups. One is whether the onset is at a focal onset or generalized onset. And the reason to differentiate this is because a lot of the drugs are developed based on whether they treat patients with focal onset seizures or generalized onset seizures. And that's because the underlying neurobiology are different depending on how the seizure starts, whether it starts in one part of the brain and then spread, in which case that's got focal onset, or starts bilaterally, in which case the network is very different, and that has in many ways driven how many of the drugs have been developed to treat, aiming to treat one or sometimes both types of these seizures, but some drugs will only work on one type and not on the other type. In some patients, we do not know the onset for many reasons. It may be very difficult to characterize. We haven't captured it on a video. We haven't captured on the EEG. Changes are not obvious. So some patients we're not able to clearly differentiate whether the seizures are focal or generalized onset. And I'm telling you all this for a reason, and it will become apparent later on. I've said before already, seizures have a lot of impact. One way to measure impact is to look at the health, the quality of life, and the economic impact. And this is a study that I was involved in, which is a survey of patients with a generalized type of epilepsy, IGE, and it just shows you the patients with. Sorry, we're looking from right to left a bit. The way the table is organized, I don't know why we organize it this way, but essentially this arrow shows you in patients who have more seizures, more high frequency of seizures from less than 1 a year, and which will essentially be seizure-free when we talk about no seizure for a year, to compare to another group of patients having 1 to 4 seizures a year to more than 1 a week. There is a corresponding reduction in their quality of life, and these are measured by these 2 measurements. One's called one measures the mental health, one measures the physical component, and these are questionnaires we ask patients, and they give us a score. And you can see patients with more seizures, they have lower and lower score in the quality of life, meaning that the quality of life is worse. And the bottom half of the table shows the cost which of associated with the epilepsy. And the indirect cost is loss of productivity, absent from work, for example, sick leave, whereas the direct cost relate to direct medical treatment cost, drug cost, test cost, investigation cost. And again, you can see patients with high seizures also need incur higher costs, both direct and indirect costs. More seriously is how seizures can lead to increased risk of death, of dying. And it's a problem that was not appreciated in the past, but much more now. In particular, there's a condition called sudden unexpected death in epilepsy, or SUDEP. And this is a condition where the patient just found dead. You might have heard of sudden cardiac death. And this is not dissimilar, but only that this happened in a patient with epilepsy. And the risk is even actually highest in the younger adult population. And they might be seen to be completely well a minute ago, and then they just found dead in bed. The reason is still unclear, likely to be due to abnormalities in the cardiac and as well as respiratory abnormalities. But we know, like in this, is a pooled study showing the importance of the role seizure plays. So in this pooled study of a pooled analysis of 4 studies, what it shows is that patients with higher frequency of the generalized tonic-clonic seizure, or GTC, and this is the third one I showed you on the right-hand side of the slide earlier on, that full body convulsion, that seizure, the more they have, then the risk of sudden death is much, much higher than someone without this seizure. So in someone who's seizure-free for 1 year, none for a year as a reference group, if you have only 1 to 2 a year, then your risk is 5 times higher. In a patient with more than just 3 of these seizures a year, their risk of dying from this condition is 15 times higher than someone who has their epilepsy controlled. The overall the condition is still uncommon, but in the order of maybe 1 in several hundred or 1 in 1,000 per year. But still, nonetheless, because this affects the younger population, tend to be affecting the younger patients at their prime age of their life, and this is really a very significant and serious problem. And it underscores why it's so important to bring the epilepsy under control, meaning to stop the seizures from happening, and to achieve this as soon as possible, because the longer you leave it, then it exposes the patients to all sorts of risks. So how do we do with medications? What is the success based on the way we use drugs at the moment? And we've been very interested in this question for a number of years. And I started researching this area when I was a PhD student in the UK, when I was studying in the University of Glasgow in Scotland, which, by the way, for those who don't know, this is in the northern part of the British Isle, and it's on the east coast. Beautiful place, very cold, and socio-economically quite deprived in many areas as well, but it has become very culturally significant, lovely place, and nice, very nice countryside. So I encourage those who haven't been there, when we can travel again, it should be on your list. But what I was able to do when I was a student there is to study patients who have been seen at the epilepsy unit, which was established in 1982 for a number of years. And patients have been followed up and treated in this clinic and by a stable team of clinicians with data collected in a very standardized form. And what this allows us to do is to assess how patients what the outcomes are, for successive patients who've been treated over the years with the successive drugs that have come onto the market and become available. of which there are many. And I'll just show you in a minute. So this was the first study we published back in 2000 when I was still a PhD student. And this study, we included 470 patients who were newly diagnosed and newly treated with medication. So these were complete drug naive patients before they started their very first anti-epileptic or anti-seizure drug. As a rule, patients are started on a single drug, which is why it's called monotherapy. So one drug, if the first drug doesn't work, then patients will be either changed to another drug, i.e. a second monotherapy, or combined with two drugs. And this is a bit of a clinical judgment, whether you add or switch. But anyway, so this is usually regarded as a second regimen. Some patients may be given the third and then combination of drugs. So here what it shows you is that for patients who were treated within this period and followed up between 82 to 1997 of these 470 patients, whether they were seizure-free at the last follow-up. And by seizure-free, it means no seizure for 12 months, because as I've shown you before, if you have one seizure a year, in 12 months, that already increases the risk of injury and dying even. So 1 year is usually regarded as the period of time to define a patient as seizure-free with the epilepsy controlled. So in this patient, this analysis, we found that most patients respond to the first drug and the second drug, but 36% of patients were not seizure-free at the last follow-up. So this was what happened in 1997. And we delve into it a little bit further of these 470 patients. What happened to the first drug? So this part, everybody would start on one drug first, as I said. So how did patient respond? About 45% will be seizure-free. The epilepsy will be controlled. They will not have seizures. But the other 55% will have seizures. And how they then do later on the last follow-up seems to depend a lot on why the drug didn't work. So the drug failed just because of it was not efficacious. Then ultimately, only 11% of these patients would become seizure-free. Whereas if the drug failed due to side effects or an allergic reaction or other reasons, then their chance of becoming seizure-free at the end would be much higher. So what it shows you is that getting the first drug, the most efficacious drug, to start with the first drug, is critically important to allow a patient to become seizure-free ultimately. Since that time, since the study has been published, there's been an explosion of new drugs. And the study, in a way, sort of gave the rationale or the evidence base of a lot of investment into finding better drugs, more effective drugs to treat, because a third of patients were not seizure-free. So that what we've seen here is a chronological development of these anti-seizure medications over time. And since the paper was published around this time, there's been many new drugs developed. In fact, in the last 30 years, there have been around 20 new drugs have been developed to treat epilepsy. And these drugs, we empirically or arbitrarily call them the newer drugs, whereas those developed in the 1930s up until the late 1980s are usually called the older drugs. So obvious questions, has these new drugs helped? We now have a lot more options. Have they really helped more patients seizure-free? A lot of these drugs also have different mechanisms of action. Not sure how many people are molecular biology or have a biology background, but this shows you a synapse, the presynaptic and the postsynaptic level. And what it tries to show you is that these are the drugs in these blue boxes. There are different drug names, and they act on either the inhibitory system or excitatory system. So there are chemicals that such as GABA, G-A-B-A, is a chemical that is neurotransmitter, the main one that is active in the inhibitory system, and whereas glutamate is the major excitatory neurotransmitter in our brain. And in a very, very simple, perhaps oversimplified way, seizures happen when there's an imbalance between excitation and inhibition. And that's why many drugs try to readjust this balance by either reducing excitation, interfering with this glutamate system, or somehow increasing the inhibition to achieve that balance again. So many drugs, as you can see, they try to interfere with this balance by acting either on the presynaptic level or the postsynaptic level. And there are different mechanisms. So you would have hoped that with more mechanisms, maybe we can help more patients seizure-free. So we did a more latest analysis of these patients, now extending the follow-up to 2014. If you remember, but the first study report included up to 1997. This time we extended for a lot more years to 2014. And the number of patients also a lot more now, with nearly 1,800 patients rather than just 470, with almost more than three times the number of patients. This is a breakdown of the characteristics for the patients, and most of these are adults in median age of 30, and most of the patients have the focal onset seizures, as I've shown you before, and that's because most of the generalized onset seizures, these so-called syndromes, tend to affect children, whereas the focal ones tend to develop in adults. So that's why this is a very common distribution we see in the overall patient population. And this slide just shows you that these new drugs, there's an increasing use of these new drugs over time. So this is the year here, and this yellow line separates those drugs at the top, which are the newer drugs, and the drugs at the bottom are the older drugs. Each color represents one drug. And as you can see on this yellow line, over time, there's a gradual reduction in the proportion of old drugs being prescribed as a proportion of all the drugs being used in each year. So you can see a gradual decline. Whereas the newer drugs, as increasingly more and more patients are being treated with the newer drugs. But despite this, what we found was that when we did the analysis, and again look at how many patients, proportional patients who were seizure-free in the last follow-up, now with this pie chart on your right-hand side, the proportion of patients who are uncontrolled who still have seizures was exactly the same. All right. So even though we have now more drugs, we're using more of the newer drugs, the overall proportion of patients who are seizure-free has not really increased. And there may be there are many reasons, and we won't go into the scientific or the neurobiological reason behind, but generally speaking, is because these are symptomatic treatment. They don't treat the root cause of the epilepsy. They're not what we call disease-modifying treatment. Another way to, and what about this observation that we made before about the importance of the first drug? And this is another way to show it, is to show with different drug regimen or schedule, going from the first drug, second, and the third, how many more patients can become seizure-free as we move along. We add more and more, or try more and more schedules. And what we found was that with the first drug or the first schedule, about 50% probability of seizure freedom. And with the second one, then it adds another 11%, third one adds another 4%. And then it gets less and less and less. So it's a typical, what you would call the law of diminishing return. And again, it highlights, and what I want to emphasize is the importance of the first drug. Getting the first drug right is critical, it's crucial. And it is, in fact, the strongest predictor of the long-term outcome. So if the first drug doesn't work, then it's the strongest predictor that the patient will still have seizures. The epilepsy is unlikely to be controlled, even though no matter how many drugs you choose. Doesn't mean that it would be impossible, but just means that their chance is much, much less. So response to the first drug is the most strongest predictor. But the way we choose the first drug at the moment is very much toss of a coin. And I said that we generally look at what type of seizures the patient is having. And most common type, as I've shown you, is the focal onset seizures. But within focal onset seizures, many drugs have been shown to have very similar efficacy in terms of how they are effective in controlling seizures. And this slide summarizes all the head-to-head randomized controlled trials. So if you're not familiar, in a randomized controlled trial, a patient is randomized to receive 1 or 2 treatment arms. And these are either rather than against a placebo. So this way you can really compare which is a better drug. And in this slide, these are all different abbreviations of drug names. And yellow line means that the 2 drugs being compared, sorry, green lines means that the 2 drugs being compared have similar efficacy, similar proportion of patients seizure-free. Whereas the red line means one is better than the other one. So you can see here, there are many, many green lines, and many drugs have shown very similar efficacy. So the clinicians will face a problem. If a patient has focal seizure, you could pick this one, this one, this one. Which one do we pick? The way we do it is look at other research, other factors that might affect how we choose a drug. And apart from the top 2 reasons here, many of these will be looking at side effects. So we look at safety. So and whether this will cause any side effects and chronically or immediately, or allergy. Teratogenicity means whether it will cause birth defects in the babies if the mother takes the medication during pregnancy. And there are some drugs, this is associated with a high risk, and obviously those drugs we would avoid in a woman who may become pregnant. Or we look for potential for drug interactions between these drugs and other drugs the patient is taking. So a lot of these are, and then try to match these drug-specific factors with the patient-specific factors, such as the age, the sex, other medications, other diseases. Can they afford it? Can they swallow pills even? And then whether drugs are available in that specific country or healthcare system. So a lot of these factors then we try to individualize in that way. But in terms of, these are more, I would call, administrative reason or safety reason. They're not looking at the real efficacy reason. And as I said, safety is an efficacy, really 2 sides of the same coin to determine whether a drug is overall effective or not. And patients have side effects, more side effects, they have a poorer quality of life, as you can see in this study here. Just quickly show this, some drugs we've looked at whether one is are better tolerated than the others. There are some examples, but overall the tolerability hasn't really changed over time. I just move a bit quickly here because I want to also show you, to give you in context how some of the nuances and the clinician will choose drug. And this is a data from a pregnancy register that register women who are pregnant while they are taking these different drugs, and the rate of major congenital malformation in the birth defects in the babies born. So you see here the red ones are the older drugs. They are higher rate, up to nearly 25% on this top dose of this drug, whereas the rate is lower for these newer ones. And this would be very difficult to, I think, to model in a machine learning system. I'll just skip this. Another factor I mentioned is drug interactions. So the clinician will look at what drugs, these are different anti-epileptic drugs, and look at whether they would induce a particular enzyme in the body called the cytochrome P450, which is in the liver, and it's a main drug metabolizing enzyme. So some of the drugs can interact through their effect on this enzyme system. So you might be scratching your head by now, like this little figure here, and the experts are trying to help. So some experts have come up with an algorithm whereby you consider a group of drugs. So as you see on the left-hand side here, so it's very small prints, but in the older days, I would say, I will apologize for small prints, but now I would say, can you lean closer to your screen? So get closer, you can probably read the small prints. So anyway, so these are different types of seizures, I said, and then these are the possible drugs that are effective. So as you can see, even for a particular type of seizure, there are still multiple drugs they can choose. And then what this algorithm does is to look at other factors that I mentioned earlier on, such as the age, for example, here, and then a hepatic failure, the liver problem, the kidney stones, then you kind of upgrade and downgrade, very complex, and these are built by a group of experts, and they have an algorithm like this to work on. So at this point, I'll just take a pause, take a step back, and you might be sharing what I'm feeling is that really we've reached a standstill with epilepsy management. We have a lot more drugs. There are many more drugs being developed. There are more choices, but the way to select is still very much trial and error. And in the trial and error process, the patient has to endure recurrent seizures before the quote-unquote right drug is found. Some algorithms, like the one I've shown you, are really just based on expert opinion. Whether following this algorithm will lead to better outcome has not been demonstrated. There's no evidence to suggest that if we follow this algorithm, the patient will do better. So what we need really is a more reliable way to predict response to specific drugs for an individual patient, not for a group basis, because on a group basis, the drugs are very similar, but for the individuals, how can we find a drug that works for one, but not for the other one? And that's possible because, as I've shown in an earlier pie chart, some patients respond to the second drug and the third drug. So you can hypothesize if the patients were given their second and the third drug, they would have become instead, and then rather than those drugs being the second and the third, they become the first, then the patients could have become seizure-free immediately, rather than having to wait until they're given their second or third drug. So how do we select that drug if we can predict that they are going to respond better to one than the other one? And that's where what the vision is to move from the current trial and error to a personalized way to select medication. And in this recent article, we propose two methods, two approaches. One is using machine learning to choose drugs, and the other one is actually have a humanized drug screening platform using neurons derived from induced pluripotent stem cells obtained from the patients themselves on a more molecular drug screening biology platform, which I'm not going to talk about. So I just focus on the machine learning aspect. I don't need to, I'm sure the audience, you will all be very familiar with increasing number of machine learning models being approved by the FDA for medical use. And I put out this one just showing a selection of them. And most of these are used in radiology, as you can see here, just by nature of for image analysis. Very few in neurology, just a very few examples here. But there is now increasing interest, and this is a company based in California that is running a study with investigators in Stanford who actually know well, trying to incorporate clinical and genomic, either omic information, physiological data, come up with a predictive model to choose medication for patients by a company called the doc.ai. What we've done is through collaboration with Zongyuan's group is to develop a machine learning model to predict response in particular to the first medication, given how important it is, as I've already shown you. So what we've done is to use a routinely available clinical data set and using information that is collected in the clinical record, the letters, the investigation results, such as the EEG, the MRI reports, not the actual images or the recording tracing, but just simple abnormal reports. And we used the data from the patient from the Glasgow cohort that I showed you earlier on to train a model, which is a transformer-based model, and then train and as well as test, and then validate that model in an independent cohort of patients that we've been following up in Perth in Western Australia. And you might say, that is crazy. You have patients in 2 different countries, but you'll be surprised how similar the Glaswegians and the Western Australians are really when it comes down to how they're predicting their response to treatment. So with this, what we've done in the fine-tuned model is to use just on the adult patients. So rather than 1,795 patients, we have 1,504 patients. These are adults, and we determined the best cutoff to determine whether to decide calculate sensitivity and specificity, and we found that 0.55 or higher probability was the best cutoff to obtain a balance between sensitivity and specificity. And using this cutoff on the Glasgow, the model has a AUC of 0.82 and a sensitivity of 83% and a specificity of 81% in predicting seizure freedom with the first anti-seizure medication used. And this is pretty impressive, as my understanding is, because it's very comparable to other FDA-approved machine learning models in disease diagnosis. When we validated in the Perth population in a complete separate cohort treated by a complete different group of clinicians, the model seems to maintain its, I think, quite good performance. There's a slight drop in AUC, but the sensitivity and specificity have both, I think, held up quite well. And this is now, we're going to present these results later in the Congress later this year. So what we then did as a next step, so this is all very well, but as a clinician, I want to apply it. How can we apply it in clinical practice? This is just looking at retrospective data, developing a model. So what our brief to our machine learning colleague was then to, well, can you then use this model actually to recommend a drug for the patient? So instead of the one they were actually given, since you can predict the success, the likelihood of success with different drugs that even the patient hasn't tried, can the model actually recommend a drug? And if that's the case, then maybe more patients will be seizure-free. And that's what we did. We simulated in a simulation way, at least. So what they were, I was, of course, deeply impressed. I was able to then use the model to recommend the first drug, and we applied this to the patients in the validation cohort, which are based in Perth, the same 336 patients. So we, to my understanding, my non-machine learning brain, the way from a clinician, I approach it is to say we actually change history. We turn the clock back and say, what if the patient weren't given the original drug? What if the patient were given this drug recommended? What the model predicted was that the median probability of seizure freedom was 63%. There's a range, but the median chance is 63%. And when we compare to the actual proportion of patients seizure-free, you can see a big difference. So in the actual cohort of patients, only 36% were seizure-free at the first year. In the Glasgow cohort, it was even less. And this is data from another study, a randomized controlled trial, showing very similar. Usually only 30% of patients would be seizure-free in the first year of treatment. But what it shows us in the model, in this simulation, hypothetical and exercise, is that potentially more patients might have been seizure-free were they given the drug the model recommended rather than the actual drug. And this is amazing. This sounds great. But then I would turn around, and as clinicians, we are very risk aversive. We want evidence. So what we're now doing is to at least we're proposing a randomized control trial to prospectively evaluate this model, to apply this in a new group of patients. And in a classical randomized control trial, what we would do is randomize patients to either the machine learning group or where the machine will recommend a drug, the neurologist will prescribe that drug, compared to the usual care group, in which the neurologist will select drugs based on their own clinical judgment. We will follow the patients up for 12 months and measure their seizure-free rate, the side effects, their quality of life, their mood, even their cost effectiveness, and how we can implement it, and compare these two group of patients to demonstrate whether using machine learning can bring both clinical and health economic benefits. And so I've been threatening my other clinical colleagues that the future epilepsy case conference may look something like this, and we'll have to find other jobs to do. So just to conclude, just to summarize again, I hope I've kind of explained the kind of predicament we really are in for epilepsy management. Despite pouring in tens of billions of dollars to developing new drugs in the past 20 to 30 years, the overall seizure freedom rate or even tolerability of the drugs has not improved. And with a third of patients still drug resistant, we know that when the first drug is failed, then it's highly likely the long-term outcome is bad. So we need to control the drug. The best chance to control the epilepsy is the first drug, but it's trial and error at the moment. But what we found, I think, is potentially our data shows that machine learning model may serve as a clinical support tool. It may not replace the clinical decision completely, because as I've shown you, there are other nuanced factors that we'll consider in choosing a drug, such as drug interactions, the risk of birth defects, and so on. So the clinician will still need to make these decisions themselves and therefore keep their jobs. But I think a machine learning model can certainly, may certainly become a decision support tool. A prospective evaluation is needed, which is what we proposed. And I guess what we should say is funding is needed, and we're keeping our fingers crossed for some of the funding applications we've made. So just my last slide to acknowledge the collaborators, in particular, of course, Zhongyuan and his PhD student, Aaron, who developed the model, Department of Neuroscience. Shibin or Ben Chen is a biostatistician who has done a lot of work in the statistical analysis. Harris is a PhD student, also an epilepsy fellow, but doing a PhD with us. Dr. Nick Lawn is the custodian and the chief neurologist in the WA Adult Epilepsy Service that provided the validation cohort, and Professor Martin Brodie heads the epilepsy unit in the University of Glasgow in Scotland. Thank you very much for listening.
Fantastic. Thank you, Professor Kwan, so much for sharing that very sort of articulate and comprehensive presentation. I think what I most valued was the depth in the sort of clinical context, understanding really the genuine clinical problem which this machine learning algorithm was seeking to address. I think so very insightful around as you say, the millions, really billions of dollars which have been invested into the development of new anti-epileptic drugs and the minimal impact that's actually had on seizure-free outcomes. So thank you so much again, Professor Kwan, for that presentation. I think we have a number of questions, which if I'm conscious of time, we have about 10 minutes left for our Q&A, but a number of questions from the audience and the co-panelists, which would be fantastic. You'd be happy to answer them. The first question is from Ruth, who asks, at this point, has the model been or may be modified for pediatric populations, sort of in terms of current training, or are there plans to modify the model for pediatric populations in the future?
Yeah, that's a very good question to ask. And the reason is because a lot of the, as I said, a lot of the types of epilepsy, the causes are very different between the pediatric adult population, and their prognosis, how drug responsive these different syndromes or different types of epilepsy are quite different. So that's why we have separated the two patient population. There's definitely a great need to adapt or modify the model before we can apply to a pediatric population. So we're currently actively seeking similar data sets. One thing I haven't pointed out though is that these data sets are very rare. And in fact, what we call is probably the largest in the world. And the reason is because most of the centers in the world have traditionally only been seeing, because of the resource reason, they focus on looking after patients who are already very refractory. They've tried a lot of drugs, they have chronic epilepsy, rather than the new onset patients. In Australia, we're lucky we have what is called first seizure clinics, where even patients who have only had one seizure, they can be seen by a specialist. But this is not common around the world. So in the US, Europe, most of the centers will only see the most difficult patients. So this sort of study is actually not easy to do. And so pediatric, so we're looking for similar pediatric cohorts to adapt the model. And the other adaptation we have to make, of course, is also look at different countries. And you can argue the Scottish and the Australian healthcare system, at least the number of drugs available are not dissimilar. The etiology, the causes are not dissimilar. But what if can we apply this to, say, an Asian country, or African country? So there will be perhaps some adaptation needs to be done because the causes are different. We don't know. Maybe we don't. Maybe there are very universal features. So this is another area of adaptation that we are trying to do.
So no, thank you so much. And the question of generalizability was one of the other questions which came up. So great that you've answered that already, Professor Kwan. The second question was around actually, what can the AI teach us with respect to an understanding of the disease itself, and perhaps the pathophysiology which underlines it. From your presentation, as Jim has sort of noted, that the difficulty of getting the first drug right, perhaps reflects the fact that we might not know enough about the mechanism of disease on a personalized level enough. So the question is, by using the AI to improve drug selection, does the AI inform us with a better understanding of the disease itself?
Yeah, so that's a good thought. If I'm understanding correctly, is the reverse knowledge transfer.
That's right.
And that's a great question. Although I've been told the AI is a black box, although I've been told that increasingly it's become a more gray box than a black box. And I think what would be very interesting to do is to look at to tease out which of the factors in the AI modeling plays the biggest role. So in our model, we have about a dozen variables, which include age, sex, and other factors, imaging, and so on. So one approach I think we might try is to find out which of these factors are most important, and then reverse engineer, if you like, to look at the underlying mechanisms.
Understood. And really the last set of questions I think we have time for are really around novel types of data, actually. So you spoke really, I found it very interesting that your team are evaluating types of data which are already routinely collected within the electronic health record, let's say. One of the questions from the audience members is, is there potential for using sensors, new innovative sensors for epilepsy, in particular, physiological or movement types of data, those potentially collected by wearable devices. What's your view, Professor Kwan, on the value of that type of data?
Yep, definitely. From collaborating with Zhongyuan, I've been taught that the machine is hungry, so the more data, the better. Other forms of data that we're interested, of course, is genomic or more looking at text data using natural language processing to look at unstructured data as well. But I think the reason we haven't yet is, well, first of all, access to the information. So these are not so widely available, and our first lowest hanging fruit we thought would be to use what's already available that is routinely collected, so that it would be most generalizable. And I think we have to, as a from a practical or very clinical perspective, is sometimes not so much whether if we add this thing, we can maybe statistically we can improve the prediction by 1 or 2%, but clinically, is it relevant? And so that is a bit of that is the trade-off for clinical implementation. Would be what kind of trade-off we're looking at. If by incorporating this information, it increase the complexity, reduce the accessibility, increase the cost, it does not make, not meeting, they become less cost effective, then one may rather choose a system that it can be more widely available and help more patients. So there is a trade-off we have to make here, I think. But we're definitely exploring these different sort of data sets.
Wonderful. Well, thank you again, Professor Kwan. I think I speak for everyone today in this webinar that this was a truly fascinating presentation, and we are all very excited for this new era of personalized epilepsy management. I think it certainly feels like that we're entering a stage where we can really achieve improved patient outcomes for people suffering with epilepsy beyond just the trial and error of new drugs alone. So it's very exciting, and we're very keen to follow the progress of your research. This talk today has been recorded, so we will be sort of including it in our sort of healthcare series workshop YouTube channel for future referral. And again, if you have any questions, our contact details were available in the advertisements for this talk. So we also very much welcome any sort of further follow-up and questions.
Great. Thank you very much. It's been a real pleasure.
Thank you, everyone. Cheers.
Thanks. Bye-bye.
Bye-bye.